nothing else. And the last brand I like to remind you all is Amino Pep, is also known as the big juice of Jamaica, the first supplement which offers all amino acids, the comprehensive formula which offers all vitamins plus zinc is also there, which boosts immunity. The first supplement, it's truly a comprehensive formula. Uh, and we know the benefit of amino acids. As you could see this screen, you will understand the benefits.
Are changed. I support healthy pregnancy by improving placental utilization and nutritional intake.
Hi, I am histidine. I play a key role in red blood cell synthesis and help combat oxidative stress associated with anemia. Hi, I'm tryptophan. I play an important role as a building block for neurotransmitters that help support normal sleep patterns and emotional balance. Hi, I'm Valine. I provide muscle energy to help maintain strength and reduce fatigue in aging individuals.
Hi, I'm Serena. I play an important role in a protein structure and supporting normal cellular integrity.
Hi, I am isoleucine. I play an important role in energy metabolism and help support the body's natural tissue maintenance processes.
Hi, I'm lysine. I play an important role utilization and help support balanced nutrition and normal appetite function. Hi, I'm leucine. I play a key role in protein synthesis and muscle function.
So that's Amino Pep, the best composition that we have it. So once again, wish you all happy New Year 2026 from Indus Life Sciences. Thank you and enjoy rest of your presentation for the day. Good day. Thank you.
All right, thank you for that infomercial. We're now going to invite our first speaker for the second session and the fourth in our dynamic lineup today. At this time, we're going to welcome Dr. Brian Cazzaro. He's a psychiatrist serving as a medical officer 3 at the Bellevue Hospital with clinical experience spanning acute psychiatry, community mental health, and university-based patient care. A graduate of the University of the West Indies, he holds an MBBS and a Doctor of Medicine in Psychiatry and is currently completing his master's in public health. Dr. Cazzaro has held several significant leadership roles, including president of both the Jamaica Psychiatric Association and the Caribbean Psychiatric Association. He has also served on multiple national boards and councils focused on mental health and disability advocacy. His career includes research work with Carmenso and a strong record of service in student development, professional associations, and public health initiatives. And so at this time, we welcome Dr. Cazzaro.
Yes, good afternoon. Thank you so much, Dr. Brown Service. I hope everyone can hear me clearly. And I just want to let people know, speaking to you from the JMDA headquarters, which I think is quite fitting because for me, the JMDA headquarters is almost like another home. I remember when I finished school, the whole idea of the JMDA is one that really fascinated me because I could see as a young doctor that, or as a junior doctor, I should say, that a lot of my colleagues were dealing with significant structural issues that actually caused them a lot of pain and trauma, as we will go and discuss in this presentation. So when I finally was able to start getting active, thanks to Ms. Harris, and eventually a vice president. And so when I got the invitation to present at this conference, it really felt like a full circle moment. So thank you to the executive for the invitation, and I'm happy to be here, and I'm happy for this presentation because I think this is an important topic. So let's begin our discussion. Trauma. So I think Dr. Eaton's previous presentation, which was an excellent one, like all the others that went before it, did a really good job of discussing what trauma is. I just wanted to break it down once more. Let's just look at some key aspects of trauma. So it's severe emotional shock. We're not dealing with something that's mild. It overwhelms a person's ability to cope. That's a big one as well. And it generally is characterized by having lasting negative effects on your mind, body, and behavior. Now, Dr. Eaton actually did a really good job of outlining the criteria for post-traumatic stress disorder, but I just wanted to reiterate the very first part of that definition, because I think it does a good job of outlining the different ways that trauma occurs. It can occur in direct exposure. It can occur when you witness something, just learning of something, or sometimes even extreme indirect exposure. And this includes things like death, serious injury, and sexual violence. You see, I wanted to talk about trauma first before we talk about trauma in the physicians, because the reality is trauma is very, very common around the world and certainly very common in Jamaica. And one thing I want us to think about is that before we even become doctors, a lot of us in Jamaica, we already experience significant trauma, right? So we're born Jamaicans, we experience trauma in our younger years before even going into medical school. And then as physicians, we also get exposed to trauma. And I think that's an important reality that we always have to bear in mind. In 2017, UNICEF did a study and it found that 8 out of 10 Jamaicans experienced childhood trauma, right? 8 out of 10. So what that suggests is that the majority of Jamaicans are going to experience some form of childhood trauma. And it would stand to reason that the majority of doctors in Jamaica likely experience some form of childhood trauma. We're going to briefly talk about adverse childhood events, just so that we're rooted in the literature. So this speaks to very negative experiences that have been studied and shown to lead to significant health issues, both mental health issues and physical health issues. Persons who experience adverse childhood events are more likely to have conditions like PTSD or depression, but they're also more likely to have things like respiratory illnesses, conditions like cardiovascular illnesses, and even cancer. Now, we can split it into, there are actually quite a few adverse childhood events. Originally it was thought of as being really just 10. But now we've kind of expanded the scope for what we'll call ACEs. But for the purposes of our discussion today, I only focused on five common ones that a lot can relate to. Abuse in its three forms: the physical abuse, the emotional abuse, and the sexual abuse. And also neglect, physical and emotional neglect. Now, Jamaica, in addition to having high rates of adverse childhood events, also has very high rates of domestic violence. It's always interesting when I talk in groups or in different settings and I ask what is the most common form of violence in Jamaica. Most people think it's gang-related or gun violence, but actually the most common form of violence in Jamaica is domestic violence. We are a violent society, but most of it is experienced in our homes. And this has a huge impact on how we process trauma as adults. Jamaica also has high rates of familial dysfunction. Again, home is supposed to be the safe space. When home becomes the area where people are traumatized or experience trauma, it can actually strip away what would have been a protective factor for many Jamaicans. Now, illnesses, and some of them include major depressive disorder, anxiety disorder, substance abuse, and PTSD. Now let's talk about trauma experienced by physicians. I just wanted to set the stage for us to appreciate that there is a process for most of us in Jamaica where we may have been exposed to some kind of trauma before we go into the medical field, and then we go into the medical field and we're exposed to very high rates of trauma. And I think it was very insightful and courageous for Dr. Eaton to even relate his own personal experience with trauma. He certainly isn't alone. Many physicians experience a lot of trauma during the COVID time. So when it comes to trauma experienced by physicians, some are patient-related, right? Witnessing the suffering of patients. All of us have seen patients deteriorate very quickly, and it can be challenging for us to have to take on, especially early in the early stages of our career. As well, sudden patient deaths. Sorry, 1 second. Oh, 1 second. Uh, 1 second, guys. I think I'm having some technical challenges. Just give me 1 minute, please. All right, I'm back. We're just ironing through some technical challenges. All right, so when it comes to trauma experienced by physicians, I don't know the last point you guys may have heard. Emphasize that for most doctors in Jamaica, they would have experienced trauma at the formative stages of their life before they would have even gotten into med school. And then they come into a profession and a career that will regularly expose them to very high rates of trauma. And so there's some patient-related forms of trauma. This includes witnessing the suffering of patients. All of us have seen patients quickly deteriorate, and it can be a very difficult thing to observe. And also sudden patient deaths. So in some cases, patients will die very quickly and abruptly, and that too can have a huge toll on the mental health of physicians, especially again in their careers. Vicarious trauma, the thing to bring to focus. Hearing about patients' traumatic experiences can cause significant emotional distress. So sometimes them even relaying some of the issues and struggles they've been going through can affect the mental health of physicians. Environment related, and I really wanted to put a spotlight on this too. Sometimes we have to deal with intense and under-resourced working spaces. And I think for most of us doctors that work in the public setting, especially within our hospitals and health centers, we know about the realities of working in under-resourced working spaces. And that too sometimes can really contribute to the trauma that physicians experience. Moral injury is another one I wanted to talk about. When actions are taken that go against strongly held beliefs by a physician, it can not only traumatize a physician, but also bring into question if they're really still in the profession for the reasons that they got into it in the first place. Moral injury can arise when there's medication shortages. And one very interesting ethical example to look at is if you have two patients and both are sick, both need some kind of procedure or some kind of intervention, but we can only administer one. Which one are you going to give it to? What if one is the relative of a colleague? Is that a justifiable reason? These are the kind of questions that sometimes physicians are faced with. And the reality is it's difficult because either way, you may in fact have to deal with an outcome that is unsatisfactory. And that, in my opinion, is one of the more unique types of trauma that we as physicians have to deal with and face. Medical errors are a reality. Research shows that medical errors are actually quite common. Now, by definition, a medical error should, one, be preventable. It's not something that is inevitable. As well, it should be unintended and undesirable. The outcome should be one that you'd have otherwise wanted to avoid. Medical errors can be due to a lot of things. Sometimes it can be the result of a flawed system. Sometimes we as doctors don't really have a huge role to play in the grander scheme of why a medical error occurred. It could have really been down to systemic problems that were never really addressed. It can also be due to an incorrect plan. So if from the get-go, the plan that put forward was one that was faulty, then that too can lead to medical errors. And then finally, improper execution of a plan can also be why you may see one, unfortunately, experience medical errors. And I can tell you that for many young physicians, a medical error is something that follows them for the rest of their life. Examples, common examples include an incorrect diagnosis, medication errors, surgical mistakes, and failures in communication. And the reality is that medical errors, again, are common, right? They've always existed from the beginning of our career or the beginning of the professionalization of medicine. And it's something that we always have to bear in mind, right? We should always be able to show empathy for our colleagues because the reality is, as I would have highlighted, there are many different factors that can contribute to a medical error. Let's talk about the prevalence. Well, one study found that nearly 80% of residents and physicians faced a traumatic or adverse patient event in a single year. So yes, the vast majority of us as doctors are likely to face a traumatic or adverse patient event this year, right? At least according to the research. And then when you look at PTSD prevalence amongst physicians, it's actually the highest across most professions, with 15 to 18% of us, almost 1/5 of doctors having PTSD. And this is 2 to 4 times higher than that in the general population. I really like the discussion that we saw in the previous presentation with Dr. Eaton when, one person asked, what really is the relevance of mental health when we're looking at trauma. I want to say that the reality is all of us are going to have a relative, a child, a parent, a sibling, a friend who is going to need medical care. And the reality is a traumatized doctor, the doctor who has experienced trauma, has not necessarily been able to process it in a healthy way, generally is not able to be as competent as a doctor who doesn't have those experiences or who had traumatic experiences and was able to process it in a productive way. So this has huge implications for us on an individual and societal level. And we really do have to prioritize helping our physicians, because the reality is trauma in our field is very common. Many of us have PTSD and other trauma-related conditions. And if we can work towards finding solutions, we can actually have a healthier Jamaica in general. Some specialties have higher prevalence: emergency medicine, general surgery and trauma surgery, and ONG. I don't think anyone's surprised to see that these ones top the list. And let's focus on solutions. So solutions to this issue have to start from the top. We have to look at leadership and management first. First, the first solution I want to mention, if we want to see systemic changes to provide mental health services. And there is some encouraging developments. I know at the University Hospital, they've recently employed a psychologist that's focusing strictly on the staff. And that's a huge step. The reality is in most hospitals, there's a kind of informal system that exists where the mental health team, the mental health professionals will do what they can to help staff, and this is all category of staff, not just physicians, but every category of staff across departments. There are issues with having an informal system like this. There are many reasons why we could benefit from a more structured and formal system that's focused on healthcare providers and of course, one that's tailored towards doctors. So this is something that we should continue to aspire to do. I am encouraged by the fact that this continues to be a discussion. Certainly with my association, the Jamaica Psychiatric Association, we've had these discussions, and the Jamaica Medical Doctor Association in the past would have had this discussion to try and highlight the importance of this. And I just want to make sure that the audience here appreciates that this is something that as doctors, we should continue to lobby for and bring up and discuss. So at least we're starting to see a move in the right direction, but there's a lot more that needs to be done. Another one is training managers to promote mental health and well-being. And when we talk about managers, we're talking about consultants and senior registrars, really. Those are the managers in our setting. And as somebody that would have been on the executive for the JMDA, I would have come across many stories when it was in fact the senior doctors who actually contributed to the trauma and mental health issues of some of the junior staff. And that, of course, that is very unproductive and a culture that we'd like to change. And I think one thing that maybe we overlook sometimes when we are looking at the production of managers is to actually give them training. Some of them may be able to, or some of them might have been able to deal with situations better had they received that kind of formal training. And what would that formal training include? 1, recognizing the signs of stress. 2, learning how to communicate with empathy. And there's a nice acronym, AER. First, we want to acknowledge trauma. Then we want to empathize. And then finally, we want to reassure. And then also teaching them to respect work-life harmony. We've all experienced a senior who might try and go what would be at the acceptable boundaries of that kind of work-life dichotomy. As doctors, we know and have to be prepared to get calls sometimes that are after our working hours. But we all have experienced seniors who kind of push that to the limit, and sometimes calling might really be considered unnecessary reasons that are outside of what would be our scope. So this is something that I think if we can encourage formal training of managers, we could see some improvement in the Jamaican context. A suicide prevention and response plan is also important. Sadly, we would have lost 2 of our younger doctors in the last couple of years. And the reality is that suicide is amongst physicians is amongst the highest rates of any profession. And so I think having a suicide prevention and response plan across our hospitals could be very useful, because trauma is experienced amongst doctors, and we need to have systems in place for when they may have suicidal thoughts or attempts. Also, a formal support peer group system would also be a useful one in my eyes. The reality is that the kind of trauma that physicians experience is one that would be difficult for persons outside of the medical profession to really be able to relate to. And I think for that reason, a support peer group would also be very useful in many of our settings. All right, so this is the second half of the presentation. I wanted us, having now looked at trauma in general, how trauma affects Jamaicans, then how trauma affects Jamaican doctors, and looking at systemic changes that we can make so that our Jamaican doctors are able to process and deal with trauma better. I wanted us to look at a very popular model that we can use on the individual level for our colleagues who might be dealing with trauma. This is the biopsychosocial spiritual model. Right? In recent years, they've added the spiritual element to it as well, because there's an acknowledgement that spiritual factors contribute to health significantly. And this is a model that I want to encourage all of us in the audience and, hopefully all of us in our profession to become at least somewhat familiar with, right? I know not everyone's interested in going into psychiatry or having a career in mental health, but this is a basic model that was actually taught in med school and one that I think can be very useful when you're trying to assess how trauma might affect our colleagues and also looking at potential treatment for our colleagues. All right, so first you have to look at biological factors. Some are inherited and some are acquired. So there's genetics and brain chemistry. We know some people are just more predisposed to experience trauma more severely or intensely than others. There have been very interesting studies where you'll take a family of like 5 siblings and all of them will have the same kind of trauma exposure, but all 5 of them react differently. So even amongst siblings who tend to have a very close kind of genetic composition, we see that there's still a variation, and that's important. We know experiencing physical trauma, diseases, and also drug use can also determine how well we can process trauma. Persons who experience physical trauma are more likely to experience emotional trauma intensely. Persons who may have chronic conditions, chronic medical conditions, and yes, our physicians have chronic medical conditions, they are also more likely to experience trauma severely. And then there's a sad relationship when it comes to substance abuse and trauma, because the reality is that many persons resort to substance abuse after experiencing trauma, but we also know that for persons who engage in excessive substance abuse, they're more likely to experience trauma intensely and are also more likely to go and do other kind of negative or maladaptive behaviors to deal with trauma. So let's talk about screening, right? This is an idea that has come up in literature recently. By screening persons with a positive family history, you can actually detect conditions early, resulting in better outcomes. So what they've shown is that if you were to actually screen physicians from an early phase, you could pick out who would be more likely throughout the course of their medical career to develop one of these kind of trauma-related conditions. And you might actually be able to intervene early. But this brings up another interesting ethical question. Should screening and assessment be utilized in helping to determine the specialty path a doctor selects or is selected for, right? It's kind of controversial, right? So if we do a screening and assessment and we find that someone is very likely to develop mental illness or experience trauma very intensely, should that really be used by the physician themselves and maybe even the panel that will determine who gets into the program to decide if this is a good path for this person, right? We already know which specialties are most likely to have trauma. We already know those. So that's an interesting one. I don't really have an answer for it, but I think that's an interesting discussion we can look into. When it comes to psychological factors, we know that core beliefs are really important. And these are just fundamental beliefs that you hold in your mind. If you have a lot of negative core beliefs or a lot of negative automatic thoughts, you are more likely to experience trauma severely, right? So this is something that if it is that you find yourself struggling with, it's something that you should try and address. This, again, is for your own self-reflection as a physician, but also it's something we can look out when having discussions with our colleagues, because sometimes these things come out. Do we experience emotions intensely and do we experience them frequently? Again, this is something you can observe in your colleagues or reflect in your own self. And again, persons like this are more susceptible to having very negative impacts when they encounter trauma. And finally, the impact of past experiences. Persons who have experienced significant trauma in the past are also at risk of responding particularly negative to trauma in the workspace. But there is a silver lining. For some persons who are able to process that past trauma, they're actually able to build a certain level of resilience that will help them deal with the trauma that they may encounter. What are the impact of negative thoughts? Well, negative thoughts can trigger or worsen mental illnesses, and it's actually a vicious cycle. Negative thinking can lead to negative feelings, which can prompt unhelpful behaviors like self-isolation. And all this reinforce the negative thoughts and distress. So you're thinking negative things about yourself or others, and that leads you to have negative feelings. And unfortunately, when people are dealing with trauma, sometimes that leads them to engage in very unhelpful behavior. And then that behavior reinforces the thoughts. So they will feel like, okay, I'm behaving like this, and so this really must be the truth. And it's an unfortunate and vicious cycle that you have to try and capture sometimes when dealing with trauma. Families, social factors are also important for physicians that may have to encounter trauma. You know, the strength of your family structure can either be a weakness or strength. We discussed how familial dysfunction can sometimes cause trauma, but the good thing is a positive family structure can also really help and be a protective factor against trauma. Culture is a big one, and we have to talk about this in our medical profession. The reality is that the culture in Jamaica is one that doesn't necessarily encourage people being open about trauma, especially trauma experienced in the workspace as physicians. We're told that this is a part of the job, you have to tough it up. And also, even mentioning something that happened, they'll just say, yeah, all of us experience this. Why are you behaving this way? I've heard comments like this, and we need to try and see if we can make a shift in the culture, because again, this is not the type of environment that will allow trauma to be processed in a productive and healthy way for our physicians. Spiritual factors. So having a sense of meaning and purpose is so important. Our career, by design, perception is one that comes with a lot of stress, and oftentimes people sometimes in the profession. This goes hand in hand with burnout, especially when they feel like they're dealing with things like moral injury, like we would have discussed before, or they feel like they're working in very under-resourced environments. They feel like they're up against it, even though they're trying their best. And then when a traumatic experience happens, it can really bring into question if they want to stay in the profession, if they're really making a positive impact. All these kind of deep existential questions can come out. So spiritual factors are very important. Connection is a powerful thing. We know it has a strong protective factor for mental health when people feel connected, which again is why I want all of us to try and see if we can foster that kind of environment within our medical fraternity. The role of the multidisciplinary team, just to say that when us as physicians have to deal with trauma, remember that we don't have to do it alone as physicians. I kind of split it into different aspects based on the biopsychosocial model. Biologically, of course, psychiatrists, doctors at large, nurses, and physiotherapists can all play a role in helping someone who might have been traumatized. Psychologists obviously play a huge role. And finally, social workers also have a role to play. Now, even though I put them into neat categories, the reality is there's significant overlap, because social workers, for instance, can certainly contribute to assisting psychologically for the traumatized physician. All right, we're going to the tail end of this discussion. We're really just about to finish. I just thought it'd be useful for us to look at the biopsychosocial spiritual approach and how it can be utilized in treatment as well. I decided just to focus on one condition, not all the different conditions that can be caused by trauma sometimes. And again, because Dr. Eaton did such a good job looking at PTSD and other trauma-related conditions, I decided I'd look at a very common one, major depressive disorder, that many physicians have to deal with. So we know that there's biological treatment options. You guys know about antidepressants. You have selective serotonin inhibitors and tricyclic antidepressants and a few other classes. I didn't want to mention all of that. We're not going to be exhaustive. I just wanted to put it out there. And also look at other biological treatment options. So for people who have treatment-resistant depression, people for whom they've tried antidepressants and have seen no improvement, there can be a role for brain stimulation. And I know people will be saying, wait, we don't have these things in Jamaica. Well, what I can tell you, without giving too much detail, is that people are working hard to try and bring these devices into Jamaica. And hopefully by the end of the year, we may have electroconvulsive therapy. We used to have it in the past, But for a lot of reasons, we decided to stop using it. But now, with it in its modern form, we think that it could be very useful, and people are working hard to try and see if we can get it in some of our public health settings. So that is something to look out for. Again, ECT is never something that we're going to use just initially as first line. It's something that we generally are going to reserve for people who we've tried medication, not just one time, but different trials of medication at adequate doses, and sadly, who still aren't necessarily able to see the kind of response they would want. I always want to talk about lifestyle because these are the things that don't necessarily have to cost a lot or require high levels of training. So just for all of us as physicians to remember the benefits of exercise, healthy diet, and getting adequate sleep, please excuse that spelling error. That should be Mediterranean diets, because that has the largest body of evidence ensuring that it can benefit with major depressive disorder. But really, if you can focus on a healthy diet, regular exercise, and getting adequate sleep, that alone can go a long way to helping with clinical depression. Psychological treatment options are also quite important. Again, as Dr. Eaton would have highlighted, psychotherapy can be so useful, and also there's a role for support groups. Just wanted to touch on common negative thoughts, or what we call cognitive distortions, that we can sometimes see in persons who might have been traumatized. Sometimes they may have an all or nothing or a black and white way of thinking or seeing the world. Things are either great or terrible. Who experience trauma, and again, especially in the medical, where they're expecting the worst possible outcomes. Every time they go to the emergency room or the operating theater, they're thinking that it's going to be a terrible outcome. Overgeneralizations can be seen. Taking one negative event that may have occurred and seeing it as a never-ending event. So because you may have experienced trauma firsthand as a physician, you think that this is going to continually happen to you again and again. And finally, emotional reasoning. You say you feel bad, and so you feel as though something bad has to happen. Now, how to handle negative thoughts. This presentation certainly could never cover the full scope of psychotherapy and psychotherapeutic techniques that are involved, and that's not necessarily my area of expertise. I just wanted to give a very practical and simple approach that some people can take and that can sometimes help with negative thoughts. It's the 3 C's. You catch it, you check it, and then you change it. First, you want to be aware when a negative thought pops in. So that's when you catch it. A negative thought is creeping in your mind and you catch it. Then you check it, you question the thought, you examine the thought, and then finally you change it, you reframe it into something more realistic or helpful. And I can tell you that many persons have told me that they've benefited from this approach. Again, this is not a replacement for a formal psychotherapeutic session that you could have with a psychologist, but this is something that's practical and useful that you can also use in your everyday life. Spiritual options. These include meditation and mindfulness and prayer. And I want to emphasize that you do not have to be religious for the first 3, meditation, prayer, and mindfulness. Even if you don't subscribe, these have all been shown by rigorous studies across different cultures to be very effective in helping persons who experience trauma, in helping persons who are dealing with major depressive disorder. I would advise everyone here to try and actually read up these processes. They're all simple. You don't have to buy any equipment. And most of them, we live in an age where we have videos and a lot of online resources from reputable sources that will actually be able to outline how to do some of these things in an effective way. But the key takeaway is you have to do these things consistently. Do them every day. Meditation, for instance, and prayer are things that you can only need to do for less than 5 minutes. But what really matters is doing them consistently and being very intentional. So for persons who have experienced occupational trauma, I do want you to consider using these options as well, please. And also participation in religious communities can go a long way, right? I know a lot of persons in the audience relate to this. I don't think I have to talk too much on that one. So in summary, trauma is common. Trauma is common in Jamaica. Trauma is common among Jamaicans. Trauma is common in medicine. Trauma is common amongst Jamaican doctors. This is a real thing. It's not something to ignore. It's something we have to take seriously and prioritize, right? And we have to try and take the steps, both individually and systemically, to help our physicians who are dealing with trauma. Because again, physicians who are affected by trauma in a very impactful way are less competent physicians. Trauma affects mental health, and we outlined all the conditions. that, well, not all, we outlined some of the conditions. Doctors are particularly high risk for experiencing trauma and trauma-related mental health. Health facilities and their leadership should all work to provide an environment that can mitigate the impact of trauma on physicians. And finally, the biosocial model is a very effective way to assess trauma in our physicians and also to manage trauma in our physicians. These are my references. Thank you very much, guys.
Thank you, Dr. Cazzaro. That was an excellent presentation, and we really appreciate your contribution to the conference today. We will be taking questions for Dr. Cazzaro at this time. And let me just check the chat to see if we have any questions here. All right. Okay, so if you have any questions, you can go ahead and post it in the chat. We'll take a short break, and then we'll come back to the questions for Dr. Cazzaro.
At Apex Radiology, we do more than just imaging. We provide answers, clarity, and peace of mind. We offer a full range of diagnostic imaging services, from X-rays to ultrasounds, CT scans, MRIs, mammograms, fluoroscopy, and interventional studies. We pride ourselves on accuracy and timely reporting because we know every answer matters. With locations in Kingston and Ocho-Rios, our team is here to serve you with care and expertise. Call us at 876-292-APEX to book your scans today. Apex Radiology, the clear choice for all your diagnostic needs.
All right. Any
Hi,
questions?
I'm Nicola Becan-Morgan, Chief Radiographer here at Apex Radiology. Today, we'll be having a discussion on what is virtual colonoscopy. Virtual colonoscopy, also known as CT colonography or CT colonoscopy, uses CT imaging to provide 2D and 3D views of the colon. It allows us to examine the colonic lumen without inserting a scope through the entire bowel, making it a less invasive alternative to conventional colonoscopy. The main indications for a virtual colonoscopy include colorectal cancer screening, detection of colonic polyps, and assessment of patients with an incomplete or failed optical colonoscopy. It is especially useful in elderly patients or those unfit for sedation. What can I find on a virtual colonoscopy? Well, virtual colonoscopy can identify polyps, colorectal carcinoma, and diverticular disease. In addition, it also provides information about extracolonic structures, which is an added advantage over conventional colonoscopy. How do you prepare for a virtual colonoscopy? Accurate diagnosis depends on good bowel preparation, including laxatives and fecal tagging. During the procedure, a rectal catheter is inserted and the colon is gently insufflated with air. CT scans are obtained in both supine and prone positions to improve visualizations. After making your appointment, you'll be advised to come in at the Winchester branch and purchase your kit. Inside this kit, there is a 50 ml syringe filled with Optiri contrast. There is also 3 20 ml syringes of barium sulfate suspension, 2 packets of Epsom salt, as well as 4 Dulcolax tabs. The barium sulfate suspension and Optiri are both used as tagging agents so that we can identify both stool and fluids respectively. A prep sheet will also be attached to your kit, which should be explained to you by the radiographer answer. On the day of your examination, you will be advised not to eat or drink. You'll also be placed in a gown and taken to the scan room. For the procedure, a small tube will be placed in the rectum, after which the radiographer will insufflate your colon for proper visualization. The scan is done in both supine and prone position, and the images obtained from both positions will build a 3D model of your colon. The virtual colonoscopy procedure takes about 15 to 20 minutes to be completed. Once the colon is demonstrated with proper insufflation, the examination is complete. Patients can return to their normal activities and your report is available within 48 hours. Virtual colonoscopy is safe as there's a lower risk of complications compared to conventional colonoscopy. It is also effective as it is accurate for screening, early detection, and identification of bowel cancer. It is also patient-friendly as it is generally better tolerated by all patients. And most importantly, virtual colonoscopy is minimally invasive as it involves a small tube compared to the long flexi tube used in conventional colonoscopy. Once you are age 45 and older, have your doctor request a virtual colonoscopy. Early detection is critical in saving lives and management of colorectal cancer, allowing for simpler treatment, vastly improve survival rates, and preventing disease from progressing before major symptoms appear. A virtual colonoscopy is far more cost-effective than conventional colonoscopy and is also covered by insurance. Go and have your virtual colonoscopy today. It's minimally invasive, not requiring sedation, having a low complication rate, and being well tolerated by patients. It plays a very important role in cancer screening and it complements rather than replaces conventional colonoscopy. Book your appointment today. All virtual colonoscopies are offered at our 3A Winchester Road branch. For appointments and queries, please call 876-929-APEX, clear choice for all your diagnostic needs.
Thank you once again, Dr. Kazara. So it would seem that your presentation was very clear and that persons do not have any questions for you at this time. However, the JMDA is very willing to facilitate any questions or queries persons may have and direct it to Dr. Kazara, who I know he'll be very willing to engage persons in another forum to clarify anything that was not clear. So again, Dr. Kazara, thank you so much for taking the time to share with us today from your wealth of experience and knowledge. And we know we'll continue to work together going forward. You're no stranger to the JMDA. There was a question about the link for the recording, and that will be sent out at a later date. And we want to ask persons, you will see an email with a questionnaire, whereas feedback questionnaire, we invite the comments and constructive criticism. And so we ask that you fill it out and send it back to us so that we can enhance the experience next year. All right, we are now going to move to our fifth speaker, and it is our pleasure to welcome Dr. John Patrick at this time. So Dr. Patrick studied medicine at King's College, London, and the St. George's Hospital, London, in the UK. John has held appointments in Britain, the West Indies, and Canada. His main academic interest in medicine is the treatment of protein energy malnutrition in various diseases and accident trauma throughout the world. His research has been carried out in the UK, Jamaica, Canada, Africa. In the 1970s, he worked with the University of the West Indies, Jamaica, also known as the Mona campus, and was involved in breakthrough of the PEM treatment whilst he was here in Jamaica. He went to Canada in 1980. At the University of Ottawa, John is an associate professor in clinical nutrition in the Department of Biochemistry and Pediatrics for 20 years. He is concerned with understanding the link between the treatment of severely malnourished, my apologies, their beliefs and their culture. Very interesting. Very, very interesting. Today he speaks to Christian and secular groups around the world, communicating effectively on medical ethics, culture, public policy, and the integration of faith and science. He frequently speaks for the Christian Medical and Dental Association in the US and the Christian Medical and Dental Society in Canada. He is currently president and professor of the history of science, medicine, and faith at Augustine College. John and his wife Sally manage the Hippocratic Registry of Physicians, whose focus is the practice of medicine as a moral activity requiring authority beyond themselves, an absolute commitment to the sanctity of life and the freedom of conscience for physicians. They have raised 4 children and 21 grandchildren. Their eldest daughter and family are missionaries in Malawi, Southern Africa. Their other children are all based in Ottawa, all attend different denominational churches, and they're all active in their church. And so it is our pleasure to welcome Professor John Patrick to our conference. All right, so we have a minor technical difficulty. We'll take a very short break while we try to unmute Dr. Patrick's mic.
By Aventa. Aventa evokes the word advance, reflecting our commitment to innovation and improving health across the region. At the heart of our logo is a spark, symbolizing the convergence of human values and science, because at Aventa, customers and patients are always at the center of what we do. So what's changing? Our pharmaceutical distribution companies in Jamaica, Barbados, Trinidad and Tobago will transition to this new name as part of our broader rebranding. Our retail operations at Superfarm, along with Linda's Bakery and Presto, M Pharmacy and Collins Pharmacy will retain their names, as well as our manufacturing companies Intisol and Carlisle Laboratories. Looking ahead, this rebranding strengthens our identity as one unified group, making it easier for us to grow, innovate, and serve our communities. Together, we're advancing health, enhancing lives. Welcome to Aventa.
At Apex Radiology, we do more than just imaging. We provide answers, clarity, and peace of mind. We offer a full range of diagnostic imaging services, from X-rays to ultrasounds, CT scans, MRIs, mammograms, fluoroscopy, and interventional studies. We pride ourselves on accuracy and timely reporting, Because we know every answer matters. With locations in Kingston and Ocho, our team is here to serve you with care and expertise. Call us at 876-292-APEX to book your scans today. Apex Radiology, the clear choice for all your diagnostic needs.
GenoMind, personalized mental health through genetics. Mental health is biologically complex. GenoMind uses genetic testing to move beyond trial and error, empowering clinicians with evidence-based insights to choose the most effective medications. Our testing evaluates how a patient's genes impact drug metabolism and response, leading to more confident prescribing and enhanced patient trust. While environment and therapy still matter, GenoMind brings the power of genetics to your treatment plan.
All right, so I believe we have fixed the glitch that we had. Dr. Patrick, are you able to hear us?
Yes, I can hear you.
Excellent.
Can you hear me?
Yes, I'm hearing you now. All right, great.
So shall I just start again or what?
Yes, you can. Yes, you can.
Okay. And I can go now?
Yes, you can go now.
Okay. In that interval, I thought I should shorten one bit. When I went to medical school a long while ago in 1958, only 3% of the population in Britain went to university. That meant that it was that had that privilege. I was fortunate to get a scholarship I knew nothing about, but God was at work in that, but that's not today's story. So I went off to medical school, which I enjoyed, got bored frequently, and spent a lot of time playing truant and climbing rock faces, which was my passion. Completed the medical course and then went into internal medicine. Also, within a year or so of starting clinical medicine as a professional, I met my wife-to-be. I met her before we got married in my second year. She shouldn't have married me, but by the grace of God, she did, and was very important in my life. Now, is very important in my life. I was ambitious. I worked hard, didn't think about it, and was successful. So I passed all the exams fairly quickly because exams were never a problem. But in Britain, you didn't get a consultant job till you were in your 30s, and I'd done all the exams by the time I was 24. So I had 6 years to fill in. So I rotated around various specialties. There weren't specialist decisions made early in those days. So I started off in internal medicine and went to neurology, gastroenterology, respirology, cardiology, pediatrics, and nephrology along the way. We were not going to have children, but we were careless, and shortly we had 3. So that required some help because my wife has only one functional arm. She said, "Can't you do something other than internal medicine for a bit? I need you home a bit more." And I was bored. I said, "Well, I've still got some years to fill in. I'll do a PhD." So I did a PhD in cell physiology, but really I did it to see my children. And it turned out it worked very well. And when it was over, Sally said, "Can't you find something to do useful with your PhD work, preferably in a warm climate?" And I went around the world looking for a problem, and I found it in malnourished children. And Jamaica was the place where the Wellcome Trust was willing to pay the bills. So we had a wonderful time here from 73 to 79 inclusive. A lovely place to bring up children. And the work was fascinating. It worked well. I wasn't an active Christian at that time. I never ceased to believe that Christianity was true. Even as a child, I read a lot of stuff, and I realized I was somewhat cynical, I suppose, that they must have believed it was true to die as martyrs in the way they did, because the early church really did grow out of the blood of the martyrs. And these were people who would know if what they were saying was a lie. It wasn't a lie to them. You're seeing the same thing happening in those parts of the world where Christians are being persecuted. People take their life seriously in that direction because of what happens to them. I grew up with good Christian parents, and I defaulted to that, but I had no experience of Christ as such, nothing personal. So all good things come to an end, and we completed the task in Jamaica, and I ended up in Ottawa, and I had grants. I brought in money, and I published. So the dean let me get away with murder, teaching biochemistry to medical students, a total waste of time. So I took a fairly cynical view of that. But the students picked up throwaway lines because I've always been interested in history and philosophy as well. And I knew that we were losing our way in the university. It was not what it used to be even back then. The writing was on the wall. And I then was bullied into going to Africa because we went to church because I wanted my children to grow up within the Christian story rather than in an empty secular one. And my wife brought some missionaries home. They discovered what I knew, and before I knew what was going on, I was finding that the whole family was going to Africa for a sabbatical for me to help a mission station with their problem of malnutrition. But really, I went to see the reality of Christian faith in the Africans, but it hadn't been provided with a Paul or a teacher. They'd become Christians in the 1930s with the Rwanda revival. That's the area we were in: Zaire, DRC, Rwanda, Burundi. And I also knew the work we'd done in Jamaica was not making any difference to the outcome of malnutrition and the prevalence of malnutrition. So I wasn't arrogant enough to think I could do something that 30 years of nutrition education had done absolutely nothing. But I trained my children to do what we'd been doing in Jamaica because I knew they would do what I told them to do, and they could make those children better. They could grow them. So all my teenage kids had the experience of looking after seriously ill children whom they came to love, and because they saved most of them, I think they all had the experience of dealing with death at that stage with a child they knew, but it didn't traumatize them. The oldest ended up spending 25 years picking up abandoned children in Malawi, so she was not traumatized. We set it up, and I trained some nurses and went away for 9 months, came back, and was not altogether surprised to find out the program wasn't working. But then came the moment of truth. One of the nurses that I trained had actually had his own child die of malnutrition. And I said to him, what on earth happened? And he told me he was going to lie by looking at the ground and not at me. And he said, well, we didn't feed him properly. But I knew that he didn't really mean that. And I sent my supervisor, I want to know what really happened. Back in a minute, he said he thought that his child was attacked by an evil spirit, and he'd spent his money on the witch doctor, and the child had died. And I went back to him and said, if I had been here, what would have happened? He said, my child would have got better. I said, why? He said, because you have a stronger spirit. This was a category I hadn't come across. But even here in Jamaica, I realized, I could think back to this. We had one child come in, was basically made into a malnourished child by the Obia man. That's another story. Spiritual realities in Africa are much stronger than they are here. Their way of thinking about the world is very different. So I didn't know what to do. But the world being the way it is, Providence being active, I had been introduced in the previous year or two to a man who became a friend, Bruce Walke, who taught theology, one of North America's best Old Testament scholars. And he gave a series of lectures in Ottawa. in which he said, if you want to understand why the Jews succeed far more than any other group, and they do, I mean, every year the Hard Nobel Prizes, sometimes 50% of them go to cultural Jews, not necessarily religious Jews, but cultural Jews. It's the culture that matters. Don't talk about racism. Don't talk about anything other than culture. It's all about culture. The reason why Jamaican and Caribbean black people do better in America than those that have grown up in America is because their cultures are better. Cultures are not equal. A culture that says you can rape any woman who doesn't share your belief is not equal to a culture that says, no, you can't do that. You've got to talk honestly and freely about these things. Now, this was really amazing. So my wife was disturbed, upset with me, because now I could see the program wasn't working. I wasn't going to go on doing the same thing. I mean, Einstein's definition of an idiot is somebody who does the same thing expecting a different result. I didn't know what the problem was. But as so often with the intuitive woman, she said, you could at least do a Bible study with the young men in the village who've been to university, came back with a degree that had no real content, but now no longer wanted to get their hands dirty. They were parasites, but they were Christian. So I said, and she said, you should do Deuteronomy. So if you ask an Orthodox Jew where this approach to life that has made the Jews so successful in the scientific sense, there's a huge story there that I'm not going to talk about now, but they will send you to Deuteronomy 6. And that's the way you raise children. And when you raise children that way, they do better. And the Jews have done that. They cope better. They're an astonishing group of people. What else can you say to a population group that can do what the Jews have done? So I started teaching Deuteronomy, and then a miracle happened, because we had to start in English, go to French, Swahili, to the tribal language. It was slow. But after a couple of weeks, 3 weeks perhaps, one of the Africans said, you know, we can go from English to the tribal language, because Mapendo has come back. And this was a young man who'd left the village for education in Tanzania and had come back 10 years later, come back speaking fluent English. So he became my translator. And perhaps the most amazing afternoon of my life, a few weeks later, I found myself at the behest of the elders of the tribe, teaching probably 6,000 people out of doors, Deuteronomy 4, 5, and 6. And the very next day, I said to them at the end of the day, Jewish fathering is what you've got to get your mind around. I know in this particular tribe, you never eat with your children, never with your girls at all, and only with the boys after puberty. That's got to change, because it's father's job, and there is such a thing as male authority, whether you like it or not, it exists. You have got to teach them all the stories of the Bible, yourself, your voice, before the age of 7. If you do that, what you've done is given them a sense of purpose, meaning, of God, and of moral consequence and educational consequence. They take it all seriously. That was amazing, because the next day, our driver said to Sally, when she was being driven from A to B, after listening to John yesterday, I went home and I didn't eat with my children, but I didn't eat first. I watched. One of my children was a slow eater, so I gave him a plate. See, this tribe eats from a common pot, so the little runt was not getting his fair share. One afternoon of the exposition of Deuteronomy 6 did more than 30 years of nutrition education had failed to do. I was blown away. I have to cut out because time is going to run out. Within a couple of years, the Rwanda war blew up. That was just a few miles away. We were actually in what was then Zaire, now the DRC. Sally was on the board of World Relief Canada, so she went up to see what was going on. She went with my son, who was starting university that fall. And they were there as the refugees flooded over the bridge. And before the UN or any international groups turned up there, only nuns and priests and evangelical Protestants could deal with the carnage. Now you see where the chaos and catastrophe goes on. I was actually in Jamaica during the hurricane, but in Kingston it wasn't a traumatic experience at all. But what my wife and son saw, I was busy doing something else a little south, was real trauma. I mean, there were 6-year-olds trying to care for 4-year-olds. There was violence, gratuitous tribal violence. Sally was noticed by the UN. She's a great organizer. She ended up running, I think it was 4 camps, including the ones with the most difficult refugees. And she did a wonderful job. But there wasn't even an email. There was no communication. I knew when I left in beginning of September that, or end of August, she was not going to be coming home for a while, because that was the year our youngest went to university. So I could look after myself while she looked after others. I went out to see her the next summer, and she knows I don't suffer from jet lag. And so the first morning back in Africa, she said, "Oh, by the way, you're going to talk to the leaders of my refugee camps this morning." I said, "What? What am I going to say? I live in an ivory tower. They've lost everything." She said, "You're exactly what they need. Wives can do that. Mine certainly has pushed me all along the way in a very practical sort of way." No point in arguing, off I went. We talked for about 3 hours, and then we got to the real question. Rwanda and that area of Central Africa is much more church-going than most other places in the world. 60% of them went to church, roughly half Catholic, half evangelical. So talking to the leaders after several hours, they said, "Well, we can't understand how we did what we did, because they'd murdered people they'd sat next to in church because they belonged to the wrong tribe. Women had burned children alive in a hut because they were from the wrong tribe. And afterwards, they appropriately felt very guilty. It wasn't a genocide that was politically organized. It was an outpouring of evil. And those that were sucked up into it, they were devastated. You want to talk about how you respond in those chaotic situations. Well, you can't do it as an ordinary human being. The UN workers who came with naturalism and secularity as their aim in life couldn't stand more than 3 days in Central Africa at the beginning. Only those with spiritual, moral fiber could work through it and start to bring some order, some semblance of order. You know, everybody has a faith. The trouble is that most people are tacit atheists. They don't actually say I'm an atheist, but they don't believe in God. They behave as though there is no God and there's no moral consequence. That is a disastrous state to get yourself into. Now, the good news for your generation is that you may be on the verge of change. I mean, it's astonishing to me to watch over the last 2 or 3 years, whole bunches of serious scholars who were naturalists have become at least deists. Now, Neil Ferguson would be an example, Tom Holland. There's a whole bunch of them who have started taking cultural history seriously. Science only happened in one culture, the Judeo-Christian one that occupied Western Europe. I don't mean science in the broader sense. Mathematics happens everywhere, but it's only really developed when physics grows. But all the people who started it did it for a very good reason, because the crown jewel of all this is experiment. You talk about evidence-based medicine now, but we may or may not get to just how much of a disaster that is too. Whose evidence, which medicine, is the two questions you have to answer. But in the end of the 13th century, temporarily the work of Thomas Aquinas was banned, but he'd already taught Western universities, which began in the 12th century, logic. But the bishop who controlled the university was worried about this new Greek learning, whether it would undermine the spirituality of the humble poor. And evangelicals to this day tend to be somewhat anti-intellectual, which is a disaster. God made minds. The New Testament tells you you must be renewed, not in how you feel, but how you think. And it began to happen, because what was banned was deductive logic. And I think we have no data for this, but this is artistic license on my part. I think someone said, well, we can't do deductive logic, but we could do inductive logic. And that's what science really is. Deductive logic starts with the big idea, the principle, and tries to work down to the details. Science says, what happens when we roll a ball down a plank and then change the angle? That's inductive science. You measure what happened and then you say, how did that happen? What theory can we come up with? How do we test it? Experimental science didn't happen anywhere else in the world, and it can't happen if you believe the world has no meaning. In Central Africa, where when we first went there, the mortality rate for the under fives was very high still. The areas we knew were beyond the road. Everybody has to answer the questions: why suffering, why pain, why this, why that. You have to have a framework for those questions. There are 9 of the questions, really. Where did I come from? Why am I here? Where am I going? Death, suffering, justice. What can I know? What ought I to believe? What ought I to do? Those 9 questions have been with human beings from the beginning of writing. They're not new. They just got forgotten in the current generation to a large degree. They certainly aren't seriously handled in our education system. But that means that the reason why a child dies is evil spirits make a better explanation than a God of love. So I'm using the word pagan not as pejorative, as a description. The pagan is someone who understands the world as being created in some distant sense, but the creator's not interested in us, and local events are under the control of evil spirits. That allows you to live, to deal with the questions of life somewhat fatalistically. But it also makes evil spirits real, and it makes it thinking about an experiment is an unthinkable thought. It takes centuries of different thinking to get to that. So now we've reached a stage where, let me put in one little step before I insult you too much. What do these men have in common? Copernicus, Galileo, Kepler, Newton, Clerk Maxwell, Faraday, Eddington. I've got name block for Boyle. All those names were involved in chemistry and physics. But I'm sure none of you knew that they were all committed Christians. That just happens to be the truth, because they could logically set about experiment. As Newton said at the end of his life, he said, I feel like I've been like a little boy sitting on the seashore, picking up pebbles, examining one, and then throwing it away for another. Nothing could please me more than to know that the work I've done would increase the strength of our faith in God. That's what he said. Read some history, honest history, not stuff coughed up last week. Do it seriously. I have a book list on my website, but I know that the odds on you reading even one book a year outside your academic requirements is negligible. We may get to that in a moment. I'm terrified I'm not going fast enough. So that experience changed my thinking in that it ordered my thoughts differently. And somehow I managed to say to medical students in the University of Ottawa that if Alan Bloom is right, you're a bunch of ignoramuses. You have no historical base, no philosophical base to your lives. And afterwards, if I said that today in a university, there'd be a riot and I'd be sent packing. But this was 1987 and students were still polite at that level. But 20 of them came and said, you need to apologize. I said, it wasn't me, it was Alan Bloom, and he's not here to complain. But if I understand him properly, he says, if you don't have a big story that will answer the big questions, you're lost. He himself was actually an atheist, but he still was Jewish and he lived with the Jewish way of doing things. But he began to understand towards the end of his life that his uneducated grandparents were wiser than he was. And I said, let me test. We're a quasi-experimental faculty. You all think Gandhi was a great man. He said the greatest literature that he'd ever read was the Sermon on the Mount. So tell me what it starts and what it says. They couldn't do it. Nothing. I said, there you are. You're ignorant. Then bless them. They changed my life. They said, what are you going to do about it? I said, nothing. It's your problem, not mine. I'm busy. They said, but you claim to know important things that we ought to know. Why wouldn't you teach us? And I said, oh, what you need is an Agnostics Anonymous group because you don't even know the basic questions, let alone the answers. And nobody's taught you how to think. You need an Agnostics Anonymous group. And they said, yes, that's right. And AA was born on the spot. A voluntary course that I taught for the next few years. Christians were not allowed to take it. You had to be an unbeliever or an agnostic to take the course. And I set out to prove to them that objective moral truth must exist. They thought I hadn't a hope, and of course, every year I won. So that really got to me. And then this takes a little while, but what happened as a result of that is my faith started to come to life. It came to life a little bit during the time I was here in Jamaica. That's where it really started. Brendan Bain was a medical student, and he went to Mona Chapel, where we went when we were here. So I met him, and we've been friends ever since. I realized that the church was not doing a good job either, but I didn't do much here. I started it Sunday afternoons. There would be students sitting on our patio while I explained to them why Marxism must fail, which of course it has. So I got back to Ottawa, and after a few years, the students got under my skin. Then I wrote an angry paper, and the net result was that within a few years, I was giving up to 400 lectures a year and going halfway around the world, not talking about biochemistry and nutrition, but talking about ethics, culture, faith, and public policy. It's been an extraordinary experience. I've been incredibly blessed. But now things are getting worse. The worst thing that's happened in the last little while, and I'm leaving a lot of things out, of course. I have, by the way, a blog, if you're interested. Dr. John Patrick podcast will find it. I do it once a week. Somebody bullied me into it a few years ago, and I'm astonished that people go to listen to my meanderings, but they do. So you can do the same if you're interested. So what I came to understand was that the big change in medicine in my lifetime is totally neglected by the academic world. I just want to read to you. I was clearing out my shelves because I'm getting old And my wife says we've got to leave the place tidier than it is at the moment. I wrote this in 1993, I think it was. Yeah, 1993, talking about limited resources in medicine. In a way, that's what you've been talking about this morning. When you are faced with a catastrophe, how do you decide priorities, etc., etc.? You're in a worse state than I was because, well, I'll read the paragraph. It won't take long, and I thought about writing it. A spectre is haunting the practice of medicine. Medicine, as we have known it, may become financially insupportable. In the developing world, the provision of even a modicum of medical care is beyond the resources of the poorest countries. The prospect of these developing world nightmares impinging on Western lives is leading physicians to think in unphysicianly ways. They are beginning to accept the role of gatekeeper. Financial considerations are beginning to distort some areas of medical practice. The idea that cost-benefit analysis judged from societal perspectives should legitimately influence what used to be primarily medical decisions is gaining ground. The ethical and philosophical implications of this change in practice are hardly mentioned. Although history suggests that they should be considered as mortal threats to the body politic, this paper will attempt to provide a Christian perspective, juxtaposing and contrasting this to the secular faith of naturalism, which is dominant in the corridors of power. It will further propose the thesis that the problem is not primarily either economics or technology, but of culture, or more precisely, the lack of it. In neither the medical fraternity nor society as a whole do we have the moral consensus necessary for what everyone would accept as a just and equitable solution. The basic limited resource, therefore, is cultural rather than material. As a society, we have agreement on neither the meaning of life, the role of compassion, and cannot therefore expect to agree on what constitutes justice in the provision of medical services. That was over 20 years ago. Astonishing, 30 years ago nearly. And it's true. When I started internal medicine, the only patients who came with a guilt trip were those who had a sexually transmitted disease. Smoking wasn't wrong at that stage. Excessive alcohol was bad, and stupid accidents were bad. But guilt was not a major part of disease. If I go to an inner city clinic for the indigent poor in North America, I like going there because they're happy places and no lawyers. And I ask the people working there, what percentage of the patients you see are responsible, at least in part, for their disease or their medical problem? And the answer, 90%. Think about that. It was just single-digit percentages when I started. Now 90% are at least in part responsible for their disease. If you're overweight, you are responsible for that because it is controllable by human character living appropriately. If you've got addicted to drugs, you are responsible for that. If you smoke, you are responsible for that. If you have anal sex, you will get bacteremias, and there will be results from that. This is just reality, but we don't talk about that now. Nobody must be judged. That's ridiculous. The world is about judgment. We all decide what we do with our time, our money, our work, whatever. That's a judgment call. We used to go to university to learn to discriminate, to know what is good, better, and best, and go after the best. Now we have DEI nonsense. The problem is the ordering of the goods. Where you have a society that has good ordering of the goods, they cope with disasters without playing the victim. Nowadays, in much of the world, people want to blame somebody else for everything instead of asking, what could I do about it? Now I'm in Jamaica. I'm speaking to Jamaicans. So here's a guy you might like to read if you haven't come across him. His name is Tom Sowell. He's written about 40 books. He's in his 90s now. You can listen to him on Uncommon Knowledge, interviewed by Peter Robinson at the Hoover Institute. He's superb. He grew up in the poorest parts of America, in North Carolina, 90 years ago, and his family realized that he was smart. And then his parents both died, and so the rest of the family said, we'll pack him off to New York, where two of the sisters had gone, and he can get a decent education, which he could in those days. He describes it beautifully in some of his books and interviews. He said when he was in the Bronx, he never heard a gunshot. In hot summer days, they'd go and sleep on the riverbank. The violence that we have now and the drug addiction is all new. I didn't see my first drug addict in England till I was 26. There was no drugs. There was no pregnancy in school to speak of. It was a very rare event. We lived by rules that we hadn't discussed. They were just the way the culture worked. Shame, yes. Honor, yes. The house I grew up in, we never locked the door. This was working class Birmingham, the equivalent of Detroit. Can you imagine that? There was no divorce to speak of. I think I can think of 2 divorces from 400 houses in the time that I was there for 18 years. These things need thinking about. Now, the first person to think about it seriously, and today's discussions would do well to go back to it again. The Abolition of Man by C.S. Lewis is only 120 pages or so. The first chapter is actually about education being turned into propaganda, which is exactly what's happened. And Lewis was writing in the 1940s. But at the end of that first chapter, he has a memorable paragraph. I can paraphrase it. And by the way, the difference between what you call learning, which is basically memorize and dump, isn't it? You couldn't pass a single exam that you took as a medical student now. That's without revision. So since you're supposed to be learning a job, you're supposed to be learning stuff of permanent significance, but it doesn't work that way, does it? But that's another discussion. But what Lewis says at the end of that chapter, he says this: for the wise men of old, the primary purpose of human life was to make a decision about what is good and what is evil. And the solution was wisdom, self-discipline, and virtue. He says for the modern man, the primary problem of human life is to make it conform to our desires. And the solution is technique. And it's going to be a disaster. He was right. I remember listening to the Reith lecture in the 1960s, just as the pill was invented. And the Reith lecture was given by the guy who invented it, and he was crowing about the fact that the pill was going to make life so much more joyful, so much more wonderful, because now we've separated the fear of pregnancy from the joy of sex. But of course, as the girls will tell the guys if they listen, but of course that's the other thing that's changed in my lifetime. You now have to deal with medicine that's going to be 90% women. That will make it very different because women organize their institutions differently. You need to think about that too, especially as biology will have its way with you, because it does. Again, we can't discuss that at the moment, but to get back on track, that distinction that wisdom, self-discipline, and virtue have got lost leads to the title of perhaps the most important book written in philosophy in the last 50 years. In fact, it's over 50 years now. And the author died just in the last year or so, Alistair MacIntyre, a guy who started off as a Marxist at Oxford and ends up as a Thomist, a Roman Catholic. Long journey. But the important book that he wrote was called After Virtue. And it begins with an amazing parable. He says, I want you to imagine that a know-nothing government takes charge. We've got plenty of corrupt governments around the world, haven't we? In fact, I can't think of many that are upright. There are one or two, I think, but not many. Europe is losing its way. America is losing its way. Canada's losing its way. Certainly, Caribbean, South Africa. Corruption at the highest levels is incredible. And the Russians, unbelievable. Tehran, all the Ayatollahs have left with $1 million in the bank, or $1 billion in some cases. That's the world we live in. And what McIntyre does, he says, I want you to imagine a world where a know-nothing government takes charge. They decided that all the problems in the world are due to science and scientists. So if we get rid of the scientists and blow up the laboratories and burn the libraries, we'll be back to a lovely green world where everybody's kind to one another. Of course, it doesn't work that way. Very shortly, the world is a lot worse. And they poke around in the ruins trying to find books and things that will help them to rebuild. And it's a fault. It's not going to happen easily. He says, but what I'm asking you to believe in this book, or to think about, is not about science and scientists, but about morals and morality. And he then does an incredible history of Western philosophy. At the end, he says something like this. He says, if you followed my argument, you will see, and this is 1979-80, that I am proposing that we've already entered upon a second dark ages. But we should not be entirely without hope, because the last time this happened, good men and women withdrew from the task of holding up the Roman Imperium into forming communities within which they kept the civilities and the virtues alive. Good manners, moral living make a difference. He said they withdrew into forming communities within which they could keep the civilities and the virtues alive. And they succeeded. The only difference is, last time the barbarians were waiting at the gate and they plundered Rome. This time they have been ruling us for quite some time. They are barbarians. They have no history, they have no culture, and they are amoral to a large degree. You see, and it is our failure to appreciate that fact that is at the heart of our problem. We are waiting for a doubtless new St. Benedict. Benedict started the monastic system, which preserved Greek learning. The Muslims looked after it for 1,000 years without understanding it. And then it came back into Europe around 1200, thereabouts. And by that time, the church had grown. I mean, 1,200 years is a long time to have to rebuild, isn't it? These things don't happen quickly. Conversion can happen to you in a moment. Nothing amazes me more than to see that happen, to watch it happen without doing anything, except in one case, leaving a book on the grass, which the guy who became a good friend picked up, read it from cover to cover that night, and it was a commentary on the book of Habakkuk, but it was exactly what he needed. And he was turned around and was looking in a different direction from his purely materialist to a deeply Christian view of the world. He once flew all the way to Jamaica to change the rear bearings on my Saab, the only one on the island. That's what happens. But it takes a long while. And Deuteronomy 6 is the solution. And then you're looking for how you form character. But we're not teaching these things. So the good news is there's a huge hunger. So don't give up. There are many things I would like to say, but I can't. But I'm going to finish with 2 or 3. The first one is your biggest problem to be able to cope in the future with tragedies of all sorts, and there'll be more of them, will be whom can you trust? trust is going to be the limiting factor in the next 50 years. And forming communities of trust, businesses of trust. You all know whom you trust, but I know trust levels are very low in North American medical schools. People say, well, there's probably one or two people in the class that I would really trust. Fogel saw that happening. He was a Nobel Prize winner in economics, Jewish, from Chicago. I happened to spend an hour with him in around 2000. Again, it was an act of God. I was there to give a lecture in the medical school, and Chicago is really proud of their university. And when you do grand rounds, it's not an hour's lecture, it was a 3-day affair. And they ask you, is there anyone you'd like to meet? And I said, if you can arrange it, I'd love to talk to Robert Fogel. And we had a wonderful discussion. But he was a secularist, a left-wing secularist, but he realized around 2000 that he no longer trusted his class in the world's most famous department of economics in the way that he used to. And he knew they were going to go off into government and Wall Street, and loyalty would trump truth. And my goodness, that is a disaster. Now, you can ask that question of your family and your friends. If there's a clash between loyalty to the people close to me, including my church and my family, and truth, which is going to win? If there's something going on in the family or in the church that I know is wrong, am I going to be loyal or am I going to be truthful? Jews and Christians are the serious Jews and serious Christians were really the only group in the world that put truth over loyalty. But truth over loyalty is the essence of science. And it's disappeared now. It's not loyalty, it's Darwinian self-interest. So we have no idea how much of the literature is fabricated, but it's huge. 80% would not be an unreasonable estimate. Jay Bhattacharya is setting out to give money to young people who want to do experiments so that they can redo experiments to make sure that they're actually valid. I hope he succeeds. That's Fogel. The next one is to realize that medicine didn't become a good idea in terms of life expectancy until the 1860s. Before that, going to the doctor actually did not correlate with a longer life. People went to the doctor because they knew they were sick. And the one thing that you know, if you see patients, even when you didn't have much treatment, which we didn't in the 50s when I started, is that you recognize natural history and you can therefore give prognosis. What medicine had to offer the world was knowledge. They could say, oh, this is trivial. There's a lot of it going around, you'll get better. Or, I'm sorry, this is going to kill you. You better get your life in order. And we all need to know those things at some point. So that's why the medical profession was trusted. Their treatments were dangerous, many of them. At least one American president probably died by being bled too much. Shouldn't be bled at all, but bleeding was one thing they could do, and it was dramatic, and so they did it. Yep, not a good idea. So the Hippocratic physicians knew that doctors killed for profit, and they're doing it again now. And they decided that trust was important, and they could do that by having 4 principles, which should happen to you, not at graduation. They were conditions of entering the profession of medicine, being taught. You must believe in judgment after death. No way around it. You must make an oath which binds you. If it doesn't bind you, it's not an oath. You must fear God. I mean, there's just pagan gods. It's amazing that polytheistic pagans came up with these amazing insights. That's principle number 1. Principle number 2 is we must make a public admission that under no circumstances will we kill you, because that will increase trust. That, of course, is now dramatically eroded. Abortion and euthanasia are rampant. Canada has become the leading killer of patients in the world. Awful, but that's where we're at. The third one, of course, is that you must provide us with the right to keep our consciences pure. That's important as well. So I missed one out. What is it? Oh, yes. The oath to moral life, totally pro-life, and conscience rights. Yeah, those principles are all being eroded. So medicine will be eroded. In your lifetime, I expect to see the re-emergence of medicine on that basis. It is beginning to happen. And of course, you may or may not know this, but the single best public health datum available to you for a cheap patient overall for a public funded health system is a letter from your priest or pastor saying you're in church 3 Sundays out of 4, at which point they know that that family will have a total lifetime cost less than 25% of that of the average Jamaican, Canadian, whatever. Why? Well, what are the big problems you face in Jamaica? Absentee fathers is number one, which is dramatic in the black community and is increasingly the same in the white one. No father. As Denzel Washington puts it beautifully, he said, boys need fathers. If there isn't one in the home, they go on the street to find somebody to be a father, and we all know what that means. Absentee fathers are absolutely essential to be dealt with, to come back to marital responsibility. So that's huge. The pill, which makes women, I've heard students say, well, if you go on a date, you feel it would be rude almost not to have sex because everybody knows you don't have to get pregnant. That's awful. Romance is dead at that point, and commitment over time. If you've never listened to Janet Smith's Contraception, Why Not? A talk with 250,000 copies at least circulating, you get it on YouTube. Do so. So drugs didn't exist. Now they're huge. Violence on children is increasing. There are good reasons for us, if we say we believe, to begin saying, okay, what should this mean? To read some history, to learn what's going on. Given that your medical school is now at least 75% women, here's 2 people you might like to read, Helen Andrews and Mary Harrington. Those 2 names you can look up. Mary Harrington was a all guns blazing lesbian, and she changed. She's the editor of Unheard, which is a superb website. The other one is Helen Andrews, and you can just put the name into YouTube on feminism, and she will make you think more carefully. Now, I have gone way over time, I'm sure, but I must stop. Thank you. I don't know whether I'll get to talk in Jamaica again. Next week I pass 86, so we'll see what happens.
Thank you very much, Dr. Patrick. And I want to thank our audience for staying with us. That was definitely a thought-provoking presentation. Much to think about, and you've given us a reading list. And one of the things you said is that the chances of us getting to read a book outside of something pertaining to our academics, it's low, and that's so true. But you have encouraged us to broaden our thoughts and widen our conversations, because these are important topics for us to consider as physicians working in an environment where we will be faced with these dilemmas, the dilemma of tragedy and trauma and ethics, that which is right, that which is good, better, and best. And this brings us to the end of our conference, we are going to take an infomercial from NCB, and then we will move to close. But thank you again, Dr. Patrick. We want to thank all our speakers, as well as our moderator, the other moderator, Dr. Samuels, who had to log off a short while ago. So the infomercial from NCB, and then we'll return to do our vote of thanks. Sorry, any questions? I'm asking you to post it in the chat. We'll take those questions. So the infomercial from NCB, we'll post our questions in the chat, and then we'll move to the vote of thanks and close.
Hi, everyone. Thanks for tuning in to the Arista Pharma Report. I hope you've been having a great conference thus far. In today's featured presentation, I'll be highlighting our best-in-class nasal spray, Flutica, as well as Arista Pharma's top-quality inhalers, Sulflo and Aeroflow. I'll also be highlighting Arista Pharma's unique eye lubricant, Cystear. And toward the end of the presentation, I'll provide a brief recap of a few of our other products. Do stay tuned, as we have quite an informative lineup ahead. Now, before we dive into the products, it's important to take a look at the company behind these innovations, Arista Pharma. Arista Pharma started its journey approximately 40 years ago with the mission of providing high-quality medications at an affordable cost. Today, Arista Pharma is one of the top 10 pharmaceutical companies in Bangladesh, exporting products to over 30 countries across 5 continents, with a robust portfolio of more than 400 products. Now, on to our featured solutions. Our first product is Flutica. Flutica is our fluticasone furoate nasal spray, indicated for patients with allergic rhinitis. Some of the benefits of Flutica include a gentle mist, no aftertaste, no drainage, reduction of ocular symptoms, and low systemic bioavailability. Flutica offers the convenience of once-daily dosing and can be prescribed for patients as young as 2 years old. It is widely available in both private pharmacies and drug-served pharmacies island-wide, making it easily accessible for your patients. Next, we'll look at our high-quality inhalers, Sulflo and Aeroflow. Sulflo is our reliable salbutamol rescue inhaler, while Aeroflow 125 and 250 are our trusted maintenance inhalers combining fluticasone and salmeterol. All of our inhalers are CFC-free, making them environmentally friendly. Sulflo has a rapid onset of action, working within 5 minutes. The relief provided by Sulflo lasts 4 to 6 hours and costs less than $300 after the NHF subsidy is applied. Now, our Aeroflow inhalers are designed for maintenance therapy. Key features include their affordability, a long history of effective asthma management, and their role in reducing COPD exacerbations. And finally, for patients who suffer from dry eyes, we have our 5-star rated Cystear. Cystear is our unique combination of polyethylene glycol and propylene glycol. Together, these polymers create a formulation that offers up to 6 times the lubricity of many other drops on the market. We encourage you and your patients to feel the hydration with Cystear. Now, as a reminder, we also offer Stafen and Olpidin as antihistamine options for allergic conjunctivitis. Both can be prescribed for patients 3 years and older at 1 drop twice daily. We also have our versatile product, Aristobet N, which is indicated for inflammatory conditions of the eye, ear, and nose. As we are at the end of our presentation, we want to thank you for tuning in. We trust you found the information informative, and we hope that as you return to your practices, you will consider including Flutica, Sulflo, Aroflow, and Cystere among your treatment options.
You take card yet? Here's how to get started with NCB ePOS so you can start receiving payments directly to your Android device. Once you have been signed up by NCB, you can then download ePOS from the Google Play Store. Update your user PIN and accept the terms and conditions along with the permissions to use the ePOS app. Great! Now you're all set. Select the desired currency and tap on Accept Card Payment. Enter payment amount and click on Confirm. Verify the payment amount and enter optional tip amount. Then click on Confirm. Tap Card on device to process payment. Click on Send Receipt. Enter customer details for electronic receipt. That's it. Quick and easy. No, there's no reason for you to say you don't take card yet.
Okay, so we do have one question for you, Dr. Patrick.
Yes.
Dr. Lynch, acknowledging that you've highlighted a number of issues with the modern practice of medicine, dilemmas that the doctor has to face. And she's asking if there are any practical steps that you would give to a young doctor working in a developing nation as we look at, how medicine is evolving in the developed nations. You stated that Canada has one of the highest rates of patient death. I'm not quite sure that's how you had put it. So she's asking for practical advice for doctors who are in the developing world navigating this dilemma.
Well, that's a big question, actually. But you can start with the questioning yourself seriously to make sure that you can make the case that objective moral truth must exist, does exist, and that therefore I need to think about faith more seriously. Now, there are two books there that you can use. I usually suggest to students, they're both by Peter Kreeft, Kreeft. The one for students is called The Best Things in Life. And the last chapter is a dialogue between an imagined Socrates landing at your medical school and a girl who's actually playing around far too much. And he says, well, we better talk about this. And so in 35 pages of double-spaced dialogue, you could put it on as a skit if you've got a couple of actors. He takes this young woman and shows her the logical consequences of what she's doing. And he changes her understanding of what a good life is without making a single statement. She makes all the statements herself. It's brilliantly done. Now, if you're further on than that, that's published by InterVarsity Press. The other one is called A Refutation of Moral Relativism, and that's published by Ignatius. And in that one, he changes his modus operandi a little bit. He has the dialogue happening between a serious Muslim, Orthodox Muslim, and a sassy black American feminist. And I'll leave you to guess who wins that one. The sassy black American feminist is a moral relativist. You mustn't judge everybody's opinions are equally valid, which is clearly rubbish once you stop and think about it. And the Muslim, of course, believes in morality and believes that it's given by Allah. So they have some way to go. But they're both written in dialogue, and they're very clever and very informative. So that would be number one, because I think what you've got to think about, I didn't have time to talk about it today, but there are really a few issues that are taken for granted and not discussed. I arrived in medical school fascinated by science. I came from a Christian background. I'd had an excellent education, but I was turned into a behaviorist type experimentalist within weeks. I thought science could answer the questions, not realizing that that was not actually true. Reductionism. The science answers all the questions. Even Dawkins has backed off now. I mean, he knows that science can't answer all the questions, that science itself needs a base which is not questionable. It's self-evident, but it's problematic. So reductionism in one form or another came into the whole of her life. Nothing buttery is what Donald Mackay called it. When somebody says, oh, you're nothing but atoms. Really? Is falling in love just atoms? Does it have no meaning, no purpose? You know that it's not like that. So that's number one. Now, once you've been caught in that particular web, you're going to move on to moral neutrality because you don't believe in objective morality. You're going to think that tolerance is a primary virtue, where it's not a virtue at all. What makes a society stable is having real intolerance of bad behavior. If Jamaica was really utterly and totally intolerant of drug use, of child abuse, of rape, and Jamaicans allowed their natural, what shall I say, power of expression to make that apparent to any who went in that direction, would Jamaica become a better place very quickly? Of course it would. When the society is powerful enough to say, you're not going to do that here. If you do, we'll lock you up until you change your mind, or whatever. So reductionism, relativism, tolerance. Now, Darwin fits into this because he was a reductionist, but it doesn't work because you can't get morality out of physical statements. Now, for the moment, you'll have to take my word for that. I can make it fairly clear in a very brief illustration, but the book to read is by an atheist called David Stove, S-T-O-V-E, called Darwinian Fairy Tales. But just imagine that you are wealthy and you're a friend of mine. And I know that when you die, I inherit your income. Now, you come to me as a patient, and MAID is now legal. And anyway, I could kill you without there being any evidence afterwards that could be obtained by biochemistry. Why wouldn't I do it? If I'm a Darwinian and everything is about a battle for the genes and looking after those genes, you're a competitor. Get rid of you. You can't handle that argument from a Darwinian point of view. So you get to an impasse on that one. And of course, that one is basically over. The two departments in the university that have the lowest rates of unbelievers now are molecular biology. You can't look at molecular biology without realizing chance, not a hope, not a hope. Just think of DNA and the fact that it can be overwritten. the probabilities of that happening by chance are negligible. They're not negligible, they're impossible. One for all the molecules in the universe would still be, it would be beyond that. And the other one, of course, is quantum physics and cosmology, which both have similar sorts of problems. The evidence from science is, it looks very much as though we are not all that we have. We're not the top dog in this story. So those things are things that you need to be able to think about and talk about. And that means you've got to establish a serious reading process. Now, those who are not Christian can tune out for a moment. But if you're Christian, one of the problems we've ceased to do well is to read seriously. And I was blessed to have that changed in my life. And it was one of the best things that ever happened to me. If you find that your faith is in the doldrums, you're just going through the motions. Use prayer. I mean, that got a push today. Of course, it should have. You live a good life. You don't have the same problems other people have, because this is not the end. This is just the training ground. You certainly couldn't do the kind of work I did, where I looked for the last 10 years primarily over children who would, well, the liberal elite want to kill them in utero before they're born. A very silly thing to do, but that's where we're at. But you have to have a bigger view of the world for that to happen. So what made me take things seriously was, I thought it was Bonhoeffer, but I can't find the reference. But somebody like Bonhoeffer or like him said, look, when you're lacking some passion in your faith, ask God to give you a passage of scripture from him to you as a personal gift. Just add it to your prayers. And it will be answered, and undeniably answered when it happens. And what you do then is you read that passage, and it should be at least a chapter, probably 2 or 3 chapters for people with the intelligence all the listeners today have. And first you read it every day until you've memorized it. And then what you will find is it starts speaking to you. It's like water falling in the desert, rain falling in the desert. It begins to bloom. And it becomes a foundational part of your life. That's really worth doing. You also need to look carefully at your friends and see if you can find a reading group of people who want to be serious, because you're living in a serious world. I mean, the economy of the world could collapse and then we'd all be back to subsistence. Would we be ready for that? I don't think so. So it's Acts 2:42. They continued the apostles' doctrine, fellowship, prayers, and the breaking of bread. So you're then building a base for your life. I hope that helps. Now, your reading must become more serious. I have N,000 books I'm sitting in my library at the moment. I could take the camera off and show you part of it at least, but you have to take my word for it. We're not reading anymore. And the other thing you can get rid of, don't look at screens any more than you need to. And if you've got children, read Jonathan Haidt's book, The Anxious Generation. You know, if you've been through medical school, that anxiety rates amongst medical students, amongst students in general, are 3 times what they were before the iPhone came along. Screens are poisonous. I've done the experiment on myself. If I want to concentrate on something, I've got to write something serious. I want to cut off all screens. And my concentration span starts to go back to what it was. When I was a student, I could read 3, 4, 5 hours without any problem. Then I started looking at computers, and worse still, I have a phone, I hardly use it because it destroys your concentration span. That should be enough to get going. You can listen to my podcast too. I burble on about these sorts of things as they come along.
Thank you. Again, a lot of gems being shared with us, practical steps on
Well,
how we can
especially
enhance. Oh, sorry.
Read Jonathan Haidt. If your children have got a phone with a screen on it that allows them to look at TikTok and the like, take it away. Australia has actually banned selling them to anybody under the age of 16. But the data is overwhelming. The Anxious Generation by Haidt, just the first chapter, just look at the graphs. There's 6 graphs in the first chapter, and they tell their own story.
Thank you. Thank you, Dr. Patrick. Yes, a number of gems there. Much for us to consider and ponder at this stage of our lives, at this stage of our career. And we really appreciate you sharing this insight. And, you know, for a man who has read thousands of books, your wealth of knowledge.
But the
don't come
best thing
across
is
it very often.
the other bit of my CV that ought to be added, you got to the 20, it's actually 22 grandchildren, and we now have 7 great-grandchildren as well.
Oh, lovely. That's wonderful.
And no divorce.
That's wonderful.
That's a miracle.
Yes. Yes. Thank you, Dr. Patrick. So we're going to move to our vote of thanks to our outstanding speakers, the distinguished guests, ladies and gentlemen. I want to give the Lord thanks for his guidance in executing this conference, another successful year of Mental Health and Ethics Conference. We extend a sincere appreciation to our sponsors, Medical Protection Society, Indus Life Sciences, CariMed, Apotex, Arista Pharma, Apex Radiology, Caribbean Genetics, CIBC First Caribbean, Majif, NCB, Aventa. Their generous contributions and sponsorship made this event possible. To our speakers, an outstanding lineup today, Dr. Brian Charles, Dr. Zinu Adeli, Dr. Jordan Eaton, Dr. Brian Casaro, and Dr. John Patrick. Amazing presentations, insightful, practical, thought-provoking. Persons were engaged meaningfully on the issues that were discussed. And so we're very grateful that they've taken the time and expertise and effort to invest in sharing your knowledge so generously. And I know that your contributions will enrich us as health practitioners, not only doctors, we do have other health practitioners online, and help to inform our work beyond today. We acknowledge RT3 Media for their professional support, and to our participants, and of course the conference committee for their dedication and hard work. Long hours, Miss George and Miss Harrison, long hours. Thank you all for joining us today. And this has brought us to the end of our conference. Have a good rest of the day. Yes, we'll send a book list based on the book recommendations from Dr. Patrick. We'll send that out in the email.